I am Bernard Herschel. Before my retirement, I was the chief of HIV/AIDS at the Geneva University Hospitals. You may call me an AIDS dinosaur who has followed the AIDS epidemic from the very first cases in the early 1980s to the current era of one-pill-a-day therapies, a triumph rarely equaled in the annals of medicine. This triumph has its flip side. Younger colleagues are no longer familiar with the opportunistic diseases of AIDS and their myriad manifestations. Hence the idea of these videos. They feature a series of images illustrating one or several exemplary case studies, mostly drawn from my files. Immune reconstitution inflammatory syndrome, or IRIS. In some patients, infections flare up shortly after the start of antiretroviral therapy, while CD4 counts rise. This flare-up is called immune reconstitution inflammatory syndrome, or IRIS. It is particularly frequent with mycobacterial diseases and particularly serious with infections of the central nervous system, where IRIS can cause irreversible damage. Case 1 was a 40-year-old woman infected by IV drug use who was admitted to hospital in January 2003 after a 5-kilogram weight loss. She weighed 42 kilograms, was highly febrile, and had swollen supraclavicular lymph nodes. The CD4 count was 54 and the viremia 545,000. The chest X-ray and the CT showed multiple enlarged lymph nodes. Routine blood cultures, urinalysis, tuberculosis, and skin reactions were all negative, but sputum and lymph node aspirates showed 3+ acid-fast rods. Acid-fast bacteria were seen in the lymph node aspirate, and culture revealed Mycobacterium tuberculosis sensitive to all TB drugs tested. This is a CT scan just before start of anti-tuberculosis treatment, showing enlarged paratracheal lymph nodes. Following guidelines current at that time, anti-tuberculosis treatment with 4 drugs was started on February 4th, 2003 with vitamin B6 and cotrimoxazole to prevent PCP, but heart was withheld. End of April, the viral load had risen further to more than 1 million and the CD4 count declined to 45. On May 2nd, 2003, heart was started with nelfinavir, tenofovir, and lamivudine. Remember, anti-TB treatment was started in February and heart in May. But in June and July of 2006, she didn't feel better because she had fever and continued weight loss. Fluctuating cervical lymph nodes yielded pus with 1+ acid-fast rods. Here is a CT scan from July 8th. Note the massively enlarged mediastinal lymph nodes and compare to the image on the left from before the start of heart. Lymphadenopathy and liquefaction is also evident in the coronal section. Under continued anti-TB therapy plus heart, the enlarged lymph nodes gradually disappeared and were no longer visible at the end of anti-TB therapy on November 9, 2003. Note that anti-TB treatment started in February, while heart started in May. In case of iris, it is typical to see acid-fast bacteria while the cultures remain negative. This is a summary of case 1. On the left, a CT scan before start of all therapy. In the middle, the CT scan after 2 months of heart plus anti-TB treatment. On the right, the appearance at the end of anti-TB treatment, with an increase in CD4 cells between the start of heart and 2 months later from 54 to 213. Case 2 was a 26-year-old man from Senegal who was HIV positive, untreated, with 158 CD4 cells, 4.6%, on April 10, 2006. He was hospitalized 10 days later because of a 20-kilogram weight loss, night sweats, diffuse migrating joint pain, and more recently, an arthritis in the right hallux with scanned joint fluid whose routine bacteriological culture was negative. He had a positive TB skin test, but the first workup for TB, including bronchoscopy, was negative. At the end of April 2006, treatment with efavirenz and combivir was started. Immediately his fever shot up to 40 degrees. He had evidence of hepatitis with increases in liver enzymes and also marked leg and hip pain, necessitating 12.5 milligrams of morphine every 4 hours. On May 5th, his hip joint fluid was aspirated, and on May 24, the culture was positive and 4-drug treatment started. Note how his latent tuberculosis flamed up after start of heart, end of April 2006. Images regarding his tuberculosis. On conventional radiographies, the right hip joint appears normal, but MRI reveals bone marrow edema and the technetium bone scan was positive. As mentioned, fluid was aspirated from the right hip joint on May 5th, and MTB was isolated on May 24th. Anti-TB treatment was started while heart was continued. Unfortunately, this was not the end of this patient's difficulties. In June and July of 2006, he had continued fever and hip pain. And in July, there was an episode of quote-unquote sepsis with hypertension, acute renal failure necessitating dialysis, liver failure with ascites, ARDS. He was treated with noradrenaline, dobutamine, and imipenem. All cultures were negative. Pus collected in his vastus lateralis leg muscle and was surgically drained 7 times between July and September 2006. All stains were negative, as were all cultures. Finally, in September 2006, on 40 milligrams of prednisone per day, plus heart plus anti-TB treatment, daily morphine doses went from 120 milligrams to 0, the C-reactive protein from 207 to 1, the lymphocytes increased from 0.6 to 1.8, the hemoglobin from 71 to 104, and the weight from 68 to 76 kilograms. Worsening of lesions of TB after start of treatment was known before AIDS as quote-unquote paradoxical reaction and may happen in HIV positive and HIV negative patients. Here's an example in an 82-year-old HIV negative woman with miliary TB. Iris may cause tuberculous lymphadenopathy, such as shown here, to worsen and to fistulize to the skin. Another example of iris of tuberculous lymph nodes with breakthrough through the skin upon start of antiretroviral therapy. The incidence of opportunistic infections decreases promptly after start of highly active antiretroviral therapy, as shown in the left panel for PCP. But non-tuberculous mycobacterial diseases are an exception. They actually increase in the first 3 months after start of HAART. This increase is largely due to iris. Mycobacteria other than TB, MOT, may also cause an increase in size of lymph nodes after initiation of HAART, as in this example due to Mycobacterium avium complex, MAC. In countries where BCG vaccination is still practiced, iris may reactivate BCG infection in immunosuppressed children. Here an example of an 8-year-old who was started on HAART a few weeks after presenting with PCP. Her mother noted swelling at the place where the girl had received BCG vaccine years earlier. There was an abscess which contained a few cubic centimeters of hemorrhagic pus. Zeal stain revealed acid-fast bacteria in a macrophage. The tuberculin skin test was strongly positive with an induration of 17 millimeters. In patients with progressive multifocal leukoencephalopathy or PML, iris may be a very dangerous complication. Symptoms may appear or pre-existing symptoms may worsen when HAART is introduced. This represents a dilemma. Without HAART, prognosis is dismal, but the transient worsening may leave behind permanent sequelae. This is also a consideration in cryptococcal and tuberculous meningitis, where HAART should be deferred. In November 2000, this patient presented with depression and gait disturbance. HIV infection was diagnosed and HAART was started. During the first 6 weeks, however, the patient became hemiplegic and aphasic. The CT scan showed several white matter lesions, one of which is shown on the left. In July 2001, while HIV infection was tightly controlled, atrophy of the left temporal lobe and parietal lobe with expansion of the fourth ventricle is evident. Serious neurologic sequelae, aphasia and hemiparesis persisted. The patient committed suicide a couple of years later. This was a 26-year-old woman with abdominal pain and extrauterine pregnancy. At laparoscopy, the surgeon, who had worked in third world countries, diagnosed probable abdominal tuberculosis. The enlarged lymph nodes were biopsied and showed on direct exam acid-fast bacteria. The CT scan confirms extensive lymphadenopathy. The HIV test was positive and the CD4 count 18 per microliter. TB therapy started on June 15th and heart on August 24th, 2006. A month after starting heart, the patient could hardly stand because of vertigo. Nystagmus was noted. The MRI showed lesions in the cerebellum and brainstem without mass effect or uptake of gadolinium. JC virus was found in the cerebrospinal fluid. These two images are from another patient who presented with neurologic symptoms after starting heart. On the right, you see a dense mononuclear inflammatory infiltrate on brain biopsy. Thank you for watching. I'd be grateful for any feedback. This video is part of a series on opportunistic diseases in HIV/AIDS. Please subscribe.